I would like to talk about is my recent work on using audio for diagnostics. And by using audio for health diagnostic, I seem to, okay. I mean, the ability of using microphones that are everywhere in our devices already carried by us to detect sounds that could be indicative of disease in our bodies. We've already seen in today's workshop presentations that hint at possibilities in this area, and I just want to introduce a couple more. So why would we do that? The fact that these devices are cheap and can be embedded in wearable and devices that we already have, such as phones, mean that the scalability of a technique that is able to automate the collection and analysis of this data would allow better health diagnostics in general. And also the ability of these devices to stick to our body and be with us all the time introduce a novel continuous sensing ability, which could be unprecedented for some of the disease diagnostics. So I have this grant that started in October, in which we hope to collect large in-the-wild data set for sounds related to cardiovascular, and it's not just heart sounds, respiratory and digestive. And I know there are many researchers that are looking into the area, but there is a really clear lack of data sets in this area. And once we have this data, perhaps we can build robust models, because what is needed is the ability of using these models in situations where noise is common, where people have collected the data differently. And we need to be able to apply this in many ways. And this could be for pre-screening. So, in a situation where you want to try to detect some sort of set of diseases and maybe refer some people to other tests. Classification of different diseases, perhaps a step further down, progression of a single disease, perhaps personalized progression, or even emergency detection. And that's really the holy grail. Can I detect if someone is having a really big problem and needs immediate assistance? Of course, in this community, we are all talking about integrating techniques on device. So the ability of perhaps for privacy reasons, but also for speeding up the detection, having things that can run on devices that stay with the user, integrate this with multi-sensing, with other sensors that can give another perspective over this, and the continuous monitoring. And of course, one part, I won't have time to talk about that, but the interpretability of the results, having the human in the loop, perhaps having an interpretation and some level of understanding of the data that allows the doctors to still be in the loop. And that's something that we hope to develop further. So we've been working with sound for quite a long time. This is a paper that I enjoy talking about. It's a 2010 Ubicon paper where we were doing emotion recognition on device using GMM. GMM were mentioned before this morning, and they're quite commonly used in audio. And I know Santosh this morning mentioned his work on stress and detection through various forms of inputs. And this is again something that was done 10 years ago. It was on device, done on a Symbian phone, so very, very effective power efficiency of those brick Nokia phones that they had. And so from there, of course, voice has been recognized as a technique and as a source of disease detection. This is a 2010 MIT Technology Review report where it says that essentially PTSD or even heart diseases could be detected through voice signals. And this is a paper, just because I'm given an invite to talk, I can talk about work of other people. This is a paper that shows that by using 999 calls data, they could, and doing simple classification, they could detect a cardiac arrest through agonal breathing detection, which is a biomarker that they used. And they also try to add noise and show that this could be something that could be ported to devices we have in our houses. But of course, that is about voice. However, we have for years had our body being listened to, and listening to the heart is a common technique that is used. It's unfortunately very commonly being substituted by echo, and doctors are coming becoming very unskilled in detecting the sound of the heart, because there are all these imaging techniques that substitute them. But if we were to consider what machines could do with the sounds of hearts, with respect to what doctor could do, listening to a heart is a very difficult technique, and consultants can do it, but junior doctors really need practicing to get it right. So, but we have computers now, we can get this data and analyze it automatically. So can we do better just with simple heart sounds? It's true for respiratory everywhere as well, but there is very limited data available. These communities are not used to collect this sort of data. They tend to train each other to listen to a patient instead of training by using data that they collect. And so that's where it starts. Another interesting, I think, problem or areas that I think we should look into is that it is unclear if the conversation with doctors can really get anywhere when we start saying, can we automatically diagnose disease X from sound coming from position Y? Because of the way the human ear is used to listen to these things, and how perhaps computers or automated diagnostic tools can do that, perhaps even continuously, this conversation with clinicians need to become deeper and more really entangled to come up with methodologies that work for new diseases. It's not just about replicating what doctors can do. So, consider this as sort of a preface. We started this project and COVID didn't exist, and now COVID came up. And of course, there is literature saying that respiratory sounds can be analyzed automatically. There are limited, but there are data sets that have proven it. There are even today, I think some of you have mentioned the detection of COPD and detection of breathing, using patterns of breathing to detect some of these things, even in terms of other aspects, perhaps sport and things. But yeah, this is something that we know as a community can be done. So what we did was we launched, and this is really recent, and you will see that from my result, this is extremely recent. We launched that website in collaboration with physicists and colleagues in respiratory biology. We started a data collection, and the platform essentially does this. This is a copy screenshots from our iOS app. It asks a user to contribute breathing sounds, cough sounds, and voice reading a sentence on the screen. And this is together with data that we crowdsourced from them on a questionnaire on medical history and on symptoms that they might have. And at the moment, the numbers are like this. So at the top right, you can see how we started at the beginning of April. And we did a media campaign, which got us quite a few samples on the web and Android platform. I can tell you a separate story on how we obviously had to wait for Google and then Apple to release our apps, going back and forward saying, well, this is not bad COVID spam app. It's actually one that tries to do something useful. And the data is kind of flattening now in a way, but the samples are continuing. So they're not, the samples you see up there are not single users, unique users, because some users are contributing more than one time in the app. And I'll explain that a bit later. Below there are statistics of participant age and countries. We do ask a location sample, but you can decide not to give it. So the biggest bar is people who decide not to give us a location sample. This is obviously dominated by European data, because it was the media campaign was mainly to Europe. We also asked the users if they tested positive for COVID. And of all the 8,000 plus users that we have, about 100 said they tested positive for COVID, because in Europe there's not been much testing, and so we don't know if the other users have COVID, and we'll see in the symptoms later. But this is where we are right now, and we're trying obviously to go into the hospitals and get more tested positive samples that would complement better our data. So this is a graph that shows a bit in a complex way the medical history. The dots on the biggest graph indicate the various diseases that the users said they have. High blood pressure, HBP, is the highest in terms of size for our user. This is just for the Android app users, by the way. And the two dots linked in the picture indicate a combination of diseases. So the most common combination is asthma and high blood pressure. This is a symptoms graph. So when I say non-COVID tested patients, well, users, this is the users for the users that said they've not been tested. Of course, they might be in that pool. There might be people who have the disease, of course. But this is a general. I'll show a bit more on that. And what we see here, essentially, the smell and taste loss is one of the common symptoms that comes up and doesn't come up in the non-COVID tested, but cough comes up in both, although the combination is slightly different. So you can start deducing some things, perhaps already from this graph. There are other symptoms tracker applications that have been on the market, and they have collected larger samples than ours on this, but just corroborates that we're getting reasonable data coming out. And this is a paper that came up on arXiv and is essentially one of the first papers that show that perhaps it's possible to show that cough samples of COVID are different from cough samples of non-COVID. They've compared the samples from hospitals, about 43 samples from hospital, with a model built on other cough databases, and it's an interesting read. So for our data, and by looking at what others are doing, there are other groups in the world that are collecting and looking at similar problems. There's one in particular in CMU, and by looking at reading and what they're saying, this is our data. So this is some sample of our data set. Essentially, a healthy cough will look like the top right there with some vocal folds there. A wet cough has a high energy spread in certain regions. And it might be that COVID coughs are something specific. And by looking at some of these, it looks like there are some characteristics of low frequency oscillations in the data that I point here that could be perhaps automatically detected. I'd say could be because I think we are all still looking at this data. And of course, all the noise in the data makes everything difficult. We have a very, very early stage arXiv paper that describes what we're doing and describes some of the initial results on some of the cough data, which I will explain in the next 2 minutes, possibly. But you know, this is not about results, it's about what we're trying to achieve at the moment. I wouldn't really you know, talk too much about the results yet because I don't seem to trust. But what we've done here is that we have used just the cough and the breathing. We haven't used the voice yet. We have extracted some features, and we've done some sort of cross-validation on the data to see if we can detect a COVID tested user from a user who said wasn't tested positive. We did one important thing when we split the data. We took what we call the non-COVID tested patients from a population where COVID wasn't prevalent. So in areas such as Greece, in particular periods such as early April, COVID wasn't yet spread. So we use those users because that would allow us to assume that they weren't COVID positive, really, even without being tested. And we start to see some signals. So the paper has these results a bit more, but we have a task, a binary task that shows COVID, can we distinguish COVID tested from non-COVID tested by just using coughs? And I can go on a bit more about task 2 and task 3, which is COVID tested that said they have a cough, and with respect to non-COVID tested that said they had a cough, and we tried that task with just the coughs to distinguish if the cough is significant and can distinguish with those. And then we try to augment our data because actually the healthy data we have that we trust is reasonably limited to all the data we have. And so we do try to, with augmentation as well. Our results, as you can see, show that perhaps there is some signal there. This is just a simple classifier. but we have a lot to do and a lot to go through, and we are while also trying to collect more data, we're also trying to analyze this data better, also with different techniques. And that's roughly where we are with this. One interesting feature that the app has is that it shows progression, in the sense that it allows the user to input data multiple times every couple of days. And we haven't looked at this, but it might be interesting to look at this further. I have lots of collaborators for this project and for the projects in general on sounds, and these are their names because I think they need to be thanked. And if you want to contribute the data or spread the word about our app, we would be happy, of course, to receive more samples. And with this, I think I'll take some questions. Thank you.